Welcome, everyone. Today, we're really going to get into the weeds on aspiration pneumonia. This is one of those conditions that's, super common, but also incredibly complex. So let's just jump right in.
All right, here's our plan. First, we'll nail down what the disease actually is. Then, we'll talk about how to diagnose it microbiologically, what bugs we're looking for, and of course, how to treat it. After that, we'll touch on prevention and complications and wrap things up with a little clinical challenge to see how it all fits together.
Okay, section 1, the disease itself. And right off the bat, we need to draw a really clear line between simple inflammation and a true infection. So, what are we really talking about here? Basically, aspiration pneumonia is what happens when you get an infection in the lungs because you've inhaled stuff from your mouth or stomach. We all probably do a little bit of microaspiration, especially when we sleep. But it becomes a real clinical issue when the amount of stuff is significant, or, more importantly, when the patient's immune system just can't handle it. And this, right here, this distinction is absolutely crucial. You've got chemical pneumonitis on one hand. That's a sterile inflammatory reaction, usually to stomach acid. It can often get better on its own. But on the other hand, you have aspiration pneumonia, which is a full-blown infection. It needs antibiotics. Getting this wrong means you're either blasting someone with unnecessary drugs or you're dangerously delaying treatment for a serious infection. All right, let's move on. Section 2 is all about the microbiological diagnosis. How do we actually figure out which bugs are causing all the trouble? Okay, so the diagnostic process is pretty logical. It follows a set path. Step 1, you've got to get a good sample. Sputum, a bowel, maybe even a biopsy. Then you do a gram stain. This gives you your first immediate clue, kind of like a first look at the crime scene. And based on that, you move on to the real workhorse, inoculating your cultures to grow the bug and see what it's susceptible to. Now, this is a key takeaway. You can't just order a standard culture and expect to find everything. There are some really fussy organisms out there. Think about Legionella or Mycoplasma. They need special media or even PCR. And anaerobes? You've got to specifically ask for those cultures, usually guided by your gram stain. The bottom line is, you have to suspect these bugs to find them. Okay, let's talk about the culprits themselves, the pathogens, and how we figure out their weak spots. So one of the first things to get your head around is that this is almost never a one-bug show. It's usually polymicrobial, a real mixed bag of aerobic and anaerobic bacteria. Anaerobes are especially tied to the nasty stuff, like abscesses or empyema. And this is critical. Where your patient is matters. If they're in the hospital, especially the ICU, your list of suspects has to include the heavy hitters, like Enterobacteriaceae, non-fermenters, and of course, Pseudomonas aeruginosa. Sometimes in the clinic, you need a little humor to get through the day. So why did the bacterium cross the airway? Well, to get to the other lung, of course. And cause more trouble, naturally. It's silly, but it kind of perfectly captures how relentless these little pathogens can be. And that brings us to what is really the cornerstone of good antimicrobial stewardship: susceptibility testing. It is absolutely non-negotiable. It's how we go from using a shotgun to using a sniper rifle. We can de-escalate from those broad-spectrum agents to something precise and targeted. It's obviously better for the patient, and it is essential if we're going to have any hope of combating antimicrobial resistance. Okay, section 3. Now we're getting to the practical stuff: therapeutic interventions. Let's look at how we tailor treatment for both adults and kids. So, for your standard run-of-the-mill case, when you don't know the pathogen yet, your go-to empirical choice is going to be IV benzyl penicillin. It's a solid, evidence-based starting point while you're waiting for those culture results to come back. But of course, not every case is standard. For your more complicated patients, we're talking about people who've been in the hospital for over a week, maybe have a head or neck cancer, or even something specific like a freshwater submersion, we need to up our game. We add gentamicin to the mix. Why? To specifically target those tougher gram-negative rods we were just talking about. Now, what if things get really bad and you're dealing with a lung abscess or a pleural empyema? This is a whole different ballgame. Antibiotics by themselves are not going to cut it. You have to hit it with a two-pronged attack. You bring in metronidazole for heavy-duty anaerobic coverage. But the most critical piece of the puzzle, and I can't stress this enough, is drainage. You have to drain that collection of pus. Source control is everything. Okay, so what about our pediatric patients? Well, the approach here is generally less aggressive, which is good news. For most kids, oral antibiotics are perfectly safe and effective, and our first-line choice is good old amoxicillin. We only bring out the IV big guns, like amoxicillin or ceftriaxone, if we see real red flags. Things like vomiting so they can't keep anything down, signs of sepsis, or other complications. And as soon as they can take meds by mouth again, we switch them right back. Right, on to section 4. Let's talk about how to prevent this from happening in the first place, and what happens when things go wrong. When we talk about prevention, a huge part of the conversation is about preventing hospital-acquired and ventilator-associated pneumonia, HAP and VAP. For those really sick, mechanically ventilated patients, there are specific strategies like selective digestive decontamination. But really, the one thing that helps everywhere, for everyone, the absolute universal precaution, is just good old-fashioned, strict, consistent hand hygiene. It's simple, but it's powerful. And the consequences, if we don't manage this well, they can be incredibly severe. We're talking about a localized infection, like a lung abscess, spiraling into a systemic, life-threatening catastrophe. Things like acute respiratory distress syndrome, or ARDS, and full-blown sepsis. These aren't just complications. They carry a huge risk of morbidity and mortality. Okay, last section. Time for a quick clinical knowledge check. Let's take everything we've talked about and apply it to a couple of real-world scenarios. All right, first question. You've got a 68-year-old man. He's been in the hospital for 2 weeks after a stroke. Now he's got a cough and a new infiltrate on his chest x-ray. So what bacterial group should your empirical coverage be targeting? Think about the single most important piece of information in his history. Okay, a quick little mini lecture on this. You have to think of the hospital as its own unique ecosystem. It's an environment that actively selects for a whole different class of bacteria, bugs that are often much tougher and more resistant than what's just floating around in the community. So where the patient has been and for how long really, really matters. And there's your answer. You absolutely have to cover for gram-negative bacteria. Why? Because that 2-week hospital stay is the giant red flag. That piece of history alone tells you that you're not just dealing with community bugs anymore. You have to plan for nosocomial pathogens like Enterobacteriaceae and Pseudomonas. Okay, next question. A patient has a severe lung abscess from their aspiration pneumonia. What's your antibiotic plan, and what is the single most critical non-drug intervention? Think about what an abscess really is. It's like a walled-off fortress filled with pus. Why might just bombarding it with antibiotics from the outside not work? And here's the key concept. A walled-off abscess is a tough nut to crack. For one, it's polymicrobial with a ton of anaerobes. But more importantly, antibiotic penetration into that dense collection of pus is terrible. Plus, the environment inside, it's acidic, it's low on oxygen. It can actually inactivate some of our best drugs. That's why simply giving antibiotics is doomed to fail. You have to address the physical collection of pus. So the only correct answer here involves 2 parts. First, the antibiotic combination, IV benzylpenicillin plus metronidazole, to get broad coverage, especially for those anaerobes. And second, the critical intervention, prompt surgical drainage of that abscess. You need both, the drugs to kill the bugs and the drainage to remove the source of the infection. Anything less is just not going to work. And this brings us to one last question to leave you with. As antimicrobial resistance continues to grow, and it is, how are we going to have to adapt these protocols to keep managing aspiration pneumonia effectively over the next decade? The principles we've covered today, they're solid, but the tools we use, our specific antibiotics, they're going to have to change. It's a constantly evolving battle. Thanks for joining me today.